we're gonna get started in just a few minutes. Let some of the committee members get here. We just got off the floor, so give us maybe 5 more minutes, we'll get started. Okay, we're going to go ahead and get started. I just found out, and I apologize to my radiologist, but we just found out that John here with dialysis group has a flight at 6:30. So if y'all just stick with me here, John, if you want to come up and start off, you go ahead and do that. This is hearing on the dialysis issue that you should have in your folders that I don't have a folder. I think it's John Hoffman. Oh, let me see. Say something again. Make sure if I try it again.
There we go.
Yeah. Okay.
Sorry, everybody. Chairman Hawkins, Vice Chairman Newton, and distinguished members of the committee, I want to thank you for the opportunity to speak to you today representing the American Kidney Fund about this important issue. The American Kidney Fund, based in Rockville, Maryland, is the nation's leading nonprofit organization working on behalf of 37 million Americans living with kidney disease and the millions more at risk, with an unmatched scope of programs that support people wherever they are in their fight against kidney disease, from prevention through transplant, with programs that address early detection, disease management, financial assistance, clinical research, innovation, and advocacy. No kidney organization impacts more lives than the AKF. On behalf of the 29,854 Georgians with kidney failure, I'm here to speak about the importance of access to affordable Medigap plans for people with ESRD, end-stage renal disease. As you may already know, people with end-stage renal disease become eligible for Medicare, and most of them choose to enroll in that program as their primary health insurance coverage. However, for many of these patients, private supplemental Medigap insurance is needed to afford the cost deductibles and copays, since Medicare covers just 80% of those costs and has no cap on out-of-pocket expenses. ESRD patients have complex healthcare needs and face high out-of-pocket costs. Average out-of-pocket costs for an ESRD patient on Medicare can be as high as $18,000 a year. Currently, Georgia requires insurers who offer Medigap plans to persons 65 years age older to also offer these plans to people under 65 who are eligible. However, under age 65 persons pay much higher premiums than over age 65, as much as 900% more in premium for the same plan paid by individuals age 65. This lack of equal treatment based on age has resulted in unaffordable Medigap premiums for qualified under age 65 financially vulnerable Georgians. As I mentioned, AKF administers a financial assistance program that helps people with kidney disease afford their insurance premiums. This allows them to pay for treatment, and it can allow them to purchase secondary coverage, which is required for them to be placed on the active transplant list. In 2022, we helped 2,927 Georgians pay for their Medigap insurance, including 2,108 people under the age of 65. The average quarterly grant amount for all these plans was $1,561. However, many of the under age 65 grant recipients face substantially higher premiums. Beverlyn G., a 63-year-old resident of Wadley, pays $3,123 per month for her plan, provided by Anthem. Bridget M., a 62-year-old resident of Macon, pays $5,264 a month for her plan by American Continental. Tom B., 49-year-old resident of Milledgeville, and James L., a 50-year-old resident of East Dublin, both paid $6,053 a month for their plans by American Continental. All these individuals and many others would not be able to afford their insurance without the financial assistance provided by our program. But these unfair premiums are limiting access to this essential insurance product for this community more broadly. Unfortunately, in Georgia, there's no premium protection on Medigap plans in place for under 65 ESRD patients. And again, without a Medicare supplemental plan, many patients are ineligible for a transplant at many transplant centers because they are considered underinsured. Since a kidney transplant is the best treatment for those with end-stage renal disease, it's not an understatement to say this legislation could save lives. It would also save the state's Medicaid program. This legislation only addresses the non-dual eligible population, so not eligible for Medicaid but eligible for Medicare by reason of disability, who in the absence of affordable secondary insurance will most likely spend down their assets until they are eligible for Medicaid, which would then pick up the 20%. Proposed legislation would consider that ESRD patients often crash into dialysis at diagnosis with little warning or ability to financially plan for the sudden and devastating consequences of managing kidney failure. Adding the annual open enrollment or protecting individuals from discriminatory underwriting or eligibility requirements helps protect this large and vulnerable population. Medigap reform will not only save lives, but it will also make it easier for patients to cope with these serious financial challenges. Thank you for your time and for your consideration of this important issue, and I'm happy to address any questions.
We're not going to take any questions from the committee today since we're running so late. If y'all can agree to that, we're going to hear this again as legislation. Senator John Albers may be having the same legislation on the Senate side, but thank you for speaking. Elizabeth, if you don't mind, can I let the radiologist go and you don't have a problem with the plane, right? Huh? I'm okay. Okay, great. Becky and Lee Martin, if y'all will come up. I'd like to say thank you to our physicians that are here today. I know that you had to change schedules to do this. You know, a lot of us that see patients understand, some that don't. Let me tell you what happens with this. These folks have had patients scheduled for probably over a month, so now they're here today on issues that they feel so impassioned about that they will end up seeing these patients that they would have seen this afternoon in the mornings, during lunch, in lieu of lunch, or at the end of the day for the next week or so. So I want to say thank you to all three of y'all for coming today. Lee Martin is a radiologist in Gainesville, Georgia. I've known Lee forever. His daddy was a physician there in Gainesville, and Lee's well known in the Georgia Medical Association and has been awarded a golden medal in radiology by their college and is well respected within his field. So I will hush up and let y'all go ahead.
Thank you, Mr. Chairman, members of the committee. I'm Becky Riles, representing Management Services Network. MSN is a Georgia-based company originating in Columbus, Georgia many years ago, and they do practice management for physician groups, including radiology groups, imaging services, not only in Georgia but across the United States. We are here today to discuss with you House Bill 434, which is legislation that was introduced in the 2023 session and is still available for action in 2024. HB 434 contemplates licensure for radiologist assistants, and this is for three reasons primarily. One, to ensure the quality of care for the patients served through imaging services, to increase the efficiency of the radiologist, which you'll hear more from with Dr. Martin in his testimony. And then finally, it addresses a workforce issue. Workforce, particularly in healthcare, is a challenge that we're seeing not only in Georgia and across the country, but across the world as well. So this creates a workforce pipeline, again, to increase the efficiency for the radiologists to be able to see more patients and as well as turn around the interpretation of those studies more quickly, and then also to ensure the quality of care for the patients. So with that, I will turn over the microphone to Dr. Lee Martin, radiologist from Gainesville, Georgia. Dr. Martin.
Thank you very much. What I'm here to do is kind of talk about what a radiology assistant is. The goal of this legislation is to increase the access to health care, radiology health care throughout the state. The problem that we have in imaging now is a supply-demand imbalance. Ever since I've been in practice, that's been over 38 years, every year there's more radiological exams to be done. Just to kind of give you an example, in Northeast Georgia healthcare systems, if you look at the number of exams that we've done in 2021, 2022, this year, and then projected for next year, there's been an increase in the number of exams, average 9.5% a year. So that's an aggregate increase of almost 44%. Yeah, I mean, and that's happening nationwide. The supply of radiologists that graduate every year has been capped. We graduate about 1,200 a year. It was uncapped, and it was capped in 1997 by the government. It was uncapped in 2022 for 5 years. We're increasing 10 spots a year nationwide, so that'll be 1,250. The ACR, American College of Radiology, saw this coming in the late 1990s, and so we formed a workforce committee. And the main thing that came out of that was this radiologist assistant. So what is a radiologist assistant? It is a person that's been through radiology technology school. They've learned how to assist radiologists in performing radiology exams. Through anatomy and physiology, they learn how to take pictures, images, x-rays, so that the radiologists and ER physicians and other people can help their patient. Once they graduate, they work for a year, at least a year, get some clinical experience. And then they go to radiologist technology assistant school. That's an 18-month school. It's kind of like a master's program for the technologists. They have book learning tests. They learn more in depth anatomy and physiology, but they also learn how to actually do procedures. They're not assisting in procedures anymore. They're doing some procedures. These procedures are well defined. There's been a supervisory committee that are made up of radiologists and radiology technologists, and they've defined which studies can be done by these special people safely, efficiently, and effectively. Once they're in school, they learn how to do these exams. A radiologist has to proctor each and every one of these students. And so they go through and they teach them how to do these procedures. They watch them as they do them, and they check off that they're efficient, they're being done safely. They have got to do so many exams, like 15 upper GIs, 15 barium minimas, and they keep a log of all these things to make sure that they've done all these things and they've learned how to do these properly. Once they've passed their boards and they've done all this, then now they're radiology assistants, and they can help extend us. They can go in and do these exams safely while we're doing other things. We're doing more complex things like reading MRIs, CTs, doing more complex interventional procedures. What this legislation does is it moves the radiologist assistant over into a mid-level provider under the umbrella of the composite board, so that they are regulated, they're licensure, and then they're ready to help us allow better access for radiology imaging in the state of Georgia.
Like I said earlier, we seem to be going at a little bit more of a rapid rate than I thought we would. So if there's any questions, let's go ahead and ask some questions. I've got one. Will they be able to bill directly to the third parties being a mid-level?
They will, I guess we could say the macro, is that, or they right now there's federal legislation. Everything happens kind of slowly in DC, but they'll be like a PA or a nurse practitioner, in that they will be billed, that we'll bill for them if they're under our employee. They will be reimbursed 85% of what a physician would get for doing that very same exam, which is exactly what happens with nurse practitioners and PAs.
Okay, but they bill under your...
That's under us, yes. we're the supervisor and we do the bill.
Oh. Mr. Chairman, I would also like to add that the reason that they are named a radiologist assistant is that they are trained and will work only for a radiologist. And they will always have direct supervision by the radiologist, which means the radiologist is on site and available the entire time that the radiologist assistant is assisting the radiologist.
Representative Sharper.
Okay, yeah, thank you, Chairman. In far as the techniques and things they're going to be doing, can you give us an idea, like cancer treatment, like radiation? Who's going to do that?
No, that's not in our purview.
That'd be interventional.
Yeah.
Okay.
We mainly interventional stuff. It will be things like putting a PICC line in, which is a fancy IV, a central line. They'll be doing some fluoro. They'll be doing an upper GI, maybe a barium minima, things like that.
Okay.
Yeah,
Okay.
Well defined. Again, things that they can do safely. They're checked off on, and again, we're in the same building. If they ever have any problems at all, we're right there to help them.
Okay. I'm thinking of. Okay, good.
Representative Petrie.
Becky answered my question, Mr. Chairman, so that by definition, as an assistant, there's no independent practice here.
Right,
I
absolutely.
knew that, but wanted you to confirm that. Thank you.
And they would lose their license if they tried to do it independently.
And for the last question, Representative Macias.
Thank you, sir. Do you have a number in mind, or will you be supervising X amount of rad techs or assistants? What will that look like?
I would go ahead.
In consultation with members of the Composite Medical Board, the number that has been recommended is 3 to 4. That a radiologist could supervise 3 to 4 radiologist assistants at any one time.
Thank you.
Now, currently, there are, practices that may or may not have that many radiologist assistants who would come to work for them. So, of course, it could be fewer than 3 to 4 as well.
One other thing I'd like to add is that they do not interpret. It's not something that they're going to be reading an X-ray or looking at a mammogram or something like that. Anything they do will come across a radiologist's desk, and they will do the interpretation.
Gotcha. Thank you.
All right, thank you very much for your presentation. Look forward to having the bill come up during the session.
Sounds great.
Thank you, Mr.
Thank y'all.
Chairman.
All right, next up, we have our, thank you. Next up, we have our cardiologist. We have Dr. Jonathan Kim, and we have Dr. John Jeffrey Marshall. I know him as Jeff. Let me tell you a little bit of something about these two fellows. Both these fellows are nationally known and are really stars in their own fields. Dr. Kim has been with the Sports Cardiology Division of Cardiology and Orthopedics at Emory University. He represents a number of the teams, the Atlanta Falcons, Braves, Hawks, Dreams, Sports Medicine at Emory and Georgia Tech. NBA, he's on the NBA Cardiac Advisory Committee, the NFL, and Major League Baseball, and the SEC. Where were you Saturday night when we needed you? Huh? Our other presenter is Jeff Marshall, and I'll tell you, I've done some legislation with Jeff years ago. When I first met him, I did not realize he was actually practicing in Northeast Georgia Medical Center because his CV is about 40 pages long. He's done things and presented in China and India and has been on about every board you can think of. I mean, I got notes all over this thing and due to the time, I'm not going to go through all that. But come to find out, he was actually one of the cardiologists in the group I was going to. I was going to Dr. Tamala, and Jeff happened to be in that same group. And when I saw him, I said, I didn't know you actually practiced. I didn't know you had time to do that. So anyway, I'm going to hush up and let y'all go ahead and talk about AEDs.
Okay, well, thank you, Chairman Hawkins and Vice Chairman Newton. Thanks for listening to us here today. I'm going to kind of start this. I'm an interventional cardiologist. I'm the chief of Northside Cardiovascular Institute at Northside Hospitals here in Atlanta. And we're here from the Georgia chapter of the American College of Cardiology. I'm the immediate past president of that organization. And I think everybody here knows that cardiovascular disease is the #1 cause of death, not just in the Western world anymore, but in the entire world. In Georgia, about 1/3 of all of us will die of cardiovascular disease. It's really a scourge. But I think few of y'all may know that the 3rd most common cause of death is out-of-hospital cardiac arrest. And I brought this as a little bit of a prop. This was something published in 2015 by the Institute of Medicine, talking about cardiac arrest survival. It turns out if you have an out-of-hospital cardiac arrest, which is most commonly going to happen at work or outside of your home, your chance of surviving and being neurologically intact so you can go home and remember your spouse or know your kids' names is 7% in this country. 7% of the people that have an out-of-hospital cardiac arrest survive and are neurologically intact. And there are lots of things that we're doing in Georgia and nationally to make that better, but it is truly a scourge. And the worst place for that to happen is in our schools. When children, no matter what age, in grade school, in high school, or in college, suffer from out-of-hospital cardiac arrest, we need to take care of them. And Dr. Jonathan Kim, to my right here, is a national expert at that, and he's going to lead you through what we'd like to request.
Thank you so much, Dr. Marshall, and thank you, Chairman Hawkins, for all your support already. Vice Chairman Newton, it's nice to meet you, and thank you to the committee for having us down here this afternoon. And Dr. Marshall, I think, set the stage beautifully for this. This is about how can we save the lives of our kids when a cardiac emergency occurs during a school setting. I'm a sports cardiologist primarily. I'm the chair of the National American College of Cardiology Sports and Exercise Cardiology Council. So, of course, I have a very strong passion as it relates to the health of athletes. And that's where we get much of the data for where this comes from across the country. And certainly this year, we've had high-profile events. We all watched on live national TV with Damar Hamlin. We heard the case of Bronny James. That was not on TV, but we know that both of these individuals had a sudden cardiac arrest while playing sports, and thankfully, both of them survived. But these are high-profile, famous athletes. This happens every day in this country, middle school, elementary school, high school. So how often does this occur? We don't have exact estimates. I certainly can't give you an estimate in Georgia, but if we look across the country, somewhere between 1 in 50 to 1 in 60,000 of these young individuals has a sudden cardiac arrest, and some of them will unfortunately not make it. So you can break that down even further. So this is an equity issue as well. We have differences in outcomes between young black athletes and young white athletes, where the risk of sudden cardiac death is actually higher for young black athletes. And this is also by sport. So believe it or not, if you just look at elite level basketball, the risk of sudden cardiac arrest or death is around 1 in 4 to 1 in 5,000. That's a shocking number if you really kind of think about that. So what can we do to save the lives of these young athletes? There's debates across the board about screening, ECGs, but what we undeniably know that can save the life of a young individual, and this is whether you're an athlete or not, is immediate CPR and immediate defibrillation. And this all comes about with emergency action planning. It's recognizing the SCA, it's starting CPR, it's getting the AED. So while that is great up front, there are certainly gaps that still exist once you have the emergency action plan and if you have an AED present. So in the state of Georgia, we're one of the best states as it relates to having some of these laws in place. There's only 7 states that say you have to have an EAP, you have to have coaches learn CPR as an example, and you have to have an AED, at least one AED present on the school side. The problem is, when you really start peeling back the layers of the onion, you start asking questions like, oh, well, that's great. Does everybody know where the AED is? Has anybody checked the batteries of the AED? Do people know how to use the AED? And do people know what they're doing? And that's not a criticism. When there's a catastrophe that exists or that happens, it's hard, right? And people, you have to practice it. You have to kind of know what you're doing. And the perfect example for this, a colleague of mine had a situation where their child, playing sports at school, had a sudden cardiac arrest. This was not in the middle of nowhere. This was within kind of really the metropolitan Atlanta area. And the child died because nobody knew where the AED was. So when you really kind of let that sink in, it just emphasizes how we have a real chance to kind of take, it's fine if you have the AED present, but again, in that circumstance, there was a real gap that occurred there. So what we are asking for, representing Georgia ACC, is to enact the legislation that already exists in terms of putting forth EAP practice drills. There are 8 fire drills that I believe I've heard occurs per year in the public school setting. 8. There are 0 EAP practice drills. And so we're asking for just 2. One per semester, where there's a team that is designed to respond to this. People have certain roles, and that these drills are meant to have a practice session for when this occurs. And if you don't think it works, it does. That's why Bronny survived, and that's why DeMar survived, because the first line responders, who in this case were the trainers, knew exactly what to do. And so this can happen at the school level, from the elementary school level all the way up. And so we're asking, again, for this from K through 12. So thank you.
All right. Have any questions? Yes.
Thank you. Thank you for this information, because this is something that's very important to me. Number one, not just from the student in the school, but I always ask the question around here, how many of my colleagues know where the AED equipment is? I mean, I know, Mark, you would know. And Dexter, you probably would know. I'd come looking for you anyway first. But most adults don't know. I have asked, and I know where they are now, but that's something that is not actually, like, where are they in CLOB? How many of them? If something should happen to me, I'm on the 6th floor, and the one is down on the 1st floor, time is of the essence. So thank you for this information. One of my questions was, where does digital health technology come into play in all of this?
Wow, that's a great question. I don't know if I have a great answer for that up front. I think even beyond kind of where we're at as it relates to digital health, AI, I mean, all these things, just having kind of a team of individuals that know kind of how to respond up front, that's kind of the low-hanging fruit. I mean, if you look at the National Football League, for example, they have this thing called I forget the exact terminology, but the providers on both sides of the teams that play meet 60 minutes before a game, and they go through the basics. Who's going to be in charge? Who's our EMS provider? Where's the local hospital that we're going to? Just to review all these basics up front. So, maybe Dr. Marshall can kind of chime in from a digital standpoint.
Yeah, I don't know that this has a real digital healthcare basis or background per se, but I would liken what we're asking for kind of being a pit crew. If you think about race drivers, they drive in and very quickly they change the tires, they put gas in the car, they do all of that. And the reason they can do that so fast is they have an action plan. Each member of the team knows their role. What we're asking for is for every school to have a pit crew. To have a pit crew so that your job is to go get the AED. My job is to start CPR. Your job is to call 911. That's what we need in schools. It's not just good enough to have the device. Batteries have got to be charged. Who does that? Those are the things that have saved lives. And we've had some unbelievable saves in this state just recently. I personally helped take care of a basketball player from a college near Macon. There was a volleyball player in Savannah, a young lady that was resuscitated, and it's on film. It's amazing. When you're prepared, you win. When you're not prepared and you don't have a pit crew, the child loses.
Yeah, I'll just add as well. I think when I give lectures now, a lot of the students that I give lectures to, and I'll mention the name Hank Gathers, and I'll say, who knows who Hank Gathers was? And nobody knows now. So I bet everybody here does. And that was a really unfortunate situation where when he arrested, the story is that he was brought off the court kind of behind the scenes before the emergency resuscitation began. Again, that would never happen. It sounds shocking because obviously we now know it's about every minute that you wait, your chance of survival decreases exponentially. So I say that because if you look at the four most high-profile recent cases, so again going back to kind of on the more kind of famous athlete side, between DeMar, Bronny, Christian Eriksen if you're a soccer fan, and Keontae Johnson if you're a college basketball fan. Now he's in the NBA. All four of them are still alive. Now, that's not to say that the success rate is going to be 100%. We all know it isn't. But the point is that it increases dramatically when you have that immediate action plan. And so that's exactly what we're asking for, is to have those practice drills. And this can really be an example for the rest of the country as well. For those of you who don't know, there's something called the National Football League Smart Hearts Coalition. This was put together in the springtime, kind of really springboarded by DeMar himself. It's sponsored by every major professional sporting organization, sponsored by the NCAA, but it's also got sponsorship by a lot of health organizations, including ACC, AHA, other very prominent health organizations out there. And what they're pushing for are legislation to push for the basics, which is you have to have one AED that's nearby, at least with either on-site or within 1 to 3 minutes of a high school athletic sporting event. Coaches have to know CPR, and there has to be a written emergency action plan. Those are the things that we're talking about. Where only 7 states have those all 3 laws. So there's a lot of work for the coalition to work on, and they're very much inundated by that. So we're trying to take things the next step because Georgia has already got the 3 laws, but we know there's a lot of work to do, and this can really be the model now for the rest of the states, because there are some states that have this. I believe Tennessee has one, and maybe Florida. Don't quote me on that one, but I know these laws do exist, and it's a real chance, I think, for Georgia to lead.
Thank you. There, in Title 20, which is the education code, we already have AED legislation sitting there that's in code. This is going to supplement this. I've already done some research and talked to some schools, and we have schools that actually have their teams set up. They call them blue teams or whatever, and they are doing this already. But this bill will put it in code and formalize all the schools going in the same direction, so it's very much needed. I don't know whether the bill will be in this committee or not for sure. It may be over in education, but still important for this committee to know about this, and I appreciate your patience. We got Representative Petrie. Excuse me, Newton. Sorry.
Thank you, Mr. Chairman. Yeah, thank you for being here, and it's good to know that we've gotten progress already, and indeed it was one of the first things I looked at 8 years ago when I got here to find out, because I know if you don't do it quickly, it's worthless. You mentioned, and tell me just real quick, have the cost of AEDs come down a lot? My original understanding was they were $4,000 or $5,000. It was prohibitive. Are they in the $1,000 net range now, or?
They're in the $1,000 to $2,000 range, mostly right around $2,000. You can buy a very good one for $1,500, $1,700. If you want one like on the back of an ambulance, those are still several thousand, because they communicate by cell towers and things with the emergency departments and things like that.
How well do you do the, like you've got a football field that's often a long way from the basketball stadium. You got baseball. I mean, is there a guideline right now in our code to say how many you have to have? I know the 1 to 3 minutes is kind of interesting, but I love the idea of adding one little thing to, you've got to have the plan and then do 2 drills a year. I know it's easy to add on mandates. We certainly see them in healthcare and every other industry, but this does sound like one. If you're going to have done all the other, you might as well do the one that's going to actually make it effective. So do they usually have one? I mean, you got to have one in the basketball gym.
Right now, at least in Georgia, it's just one per school. So it's not necessarily.
Well, if you do a couple of drills, you might find out they're further than 3 minutes away. You wouldn't know until you do a drill.
Exactly.
That somebody has to run to the football stadium or the baseball field to the basketball stadium, and there's pretty big high schools. But
that's exactly right. But yeah, that's the I don't know the breakdown. Obviously, I'm sure there's some schools that have more than one, but per the law, it's just one.
Your odds of surviving if you get CPR and a defibrillation within 4 minutes of onset are enormously higher than if it's after 4 minutes. So that's where the 1 to 3 minutes comes in.
Thank you.
Representative Petrie.
Yes, thank you, Chairman. Yeah, just to clarify, so these drills, you mentioned the pit crew kind of description. this is not something that encumbers the totality of the campus and learning throughout. This is just that pit crew, right? Those individuals that would be involved. It's pretty, one would hope that folks are doing this anyway. If you invest and are required to have these, that they would be doing that. But it's not something that is going to disrupt the campus and learning that takes place on
That's exactly
on that
right.
campus. Thank you. I just wanted to clarify that.
It's not like all the kids lining up and walking out
Right.
onto the
Right,
recess
exactly.
field.
I have
right,
a hard
it's
time understanding why they wouldn't be doing this anyway.
Yeah,
That's my
it's
point.
a few people and some, somebody grading it.
Along those lines, schools already have drills for the entire school, in a lot of schools, for CPR. And so this AEDs, a shorter training period, but those that are doing AEDs are typically the teams, the blue teams and things like that. They're also doing CPR. AEDs are shorter training session. So, we have a lot of possibilities out there. Representative Gunter.
Thank you. I'm the lawyer on the committee. So the way these teams would be set up would be for each different sport. Is that right?
No, just for the school. So there would be kind of a designated individuals, a kind of a team lead who would be the overall coordinator of the response, making sure people are doing their respective roles, who's directing traffic, who's getting the AED, making sure the person in charge of CPR is doing that. But there's a specific lead for each of that. So the AED lead knows where the AEDs is at. It's obviously in charge of ensuring that they know battery upkeep, all these things. They get the AED. The CPR lead initiates CPR, and then the communication lead is the one that's ensuring that appropriate communications are in place. That's ensuring when EMS gets there, they direct EMS to the scene, because that's the other kind of big issue is once EMS gets there to know exactly where to go. And so the ask initially is a minimum of 5 people on the team. It can certainly be larger because it'd be nice to have more than one that can serve different roles, but kind of the minimum description would be a team of 5 as kind of the response team.
Okay, so what I'm thinking about is a football team out on the practice field that's a good distance from the high school. Is your legislation to require that device be located on the field where they're practicing, or is it still going to be back at the school where somebody has to go and get it and get the message out that this is going on and get everybody there to use it?
No, that's a really good point. I mean, that goes to the question as well about the where the 1 to 3 minutes comes from, how many AEDs are present. I mean, there's clearly challenges that can come about if you're at a bigger school and the school can only have one AED. But, part of the legislation also mandates that coaches have to know CPR. So part of the team is your trainer and the CPRs that are already there. That's kind of the emergency response team already. And initiation of CPR can certainly be started, and then if the AED happens to be at a separate location, that's a part of the emergency response, the EAP, which is, okay, so we know the AED is wherever it is. This is going to be our plan that whoever is in charge of that, that's their role, is to get it and come back. And obviously, as soon as possible, as a part of kind of what's going, with the emergency situation that's going on. But I mean, to your point, I think there are obviously circumstances where this can become complex and challenging because not every school is going to be able to have more than one AED. But the bottom line is that you still have to initiate kind of that plan to be able to think some of these things through for situations like that. Maybe if that's the only fall sport and the school is not necessarily, if everybody's dismissed, maybe a part of the plan is the AED is brought from wherever it's stored in the school out to kind of the fields where you've got the football team practicing, or during the winter time where the basketball team is, and perhaps where some of the other fall sports are practicing as well as a part of the design plan. It could be unique to every school depending on how many devices they have and what they see as best fit for their specific school.
So this will be a required plan put in place for every school?
Yes.
Is that right? Okay. Elementary as well?
Yes.
Okay.
Representative Cannon.
Yes, thank you, Mr. Chairman. I would just say from my experience, our county, at most major sporting events, say a football game, There's an ambulance co-located on the field. There's multiple medical physicians on the sideline, and there's EMS personnel along with, law enforcement at the stadium. And that's probably by design to protect the players and the crowd. So I agree with Chairman Gunner. I mean, if you have these events might happen at practice, and
Absolutely.
how do you drill down to allocate resources for those events where there might not be an ambulance or multiple, medically trained physician close by to treat the player or the coach. So even in schools, I know our high school has, I think, 8 SROs. So maybe there's a way to cross-train them in some of these things. They can also have a useful purpose there.
Good point.
Representative Sharper?
Thank you again. Looking at this, I think if we'll be able to legislate these things, a lot of the schools already have a school nurse, and they just need to build a team around that when it comes out to school itself. But also think, for the practices, with the coaches that have to do the CPR, is to have a separate one. And I think, a lot of people pay a lot of money for these tickets at these stadiums and these fields, that I think it should be a separate one. Just because of the distance or the school nurse doing what she's doing, she's not going to be coming to every game. But I think this is a great idea, but just keep in mind we want to make sure they're where they need to be with the teams and everything. And I just want to mention for the record, I think that if we don't have one already, but even for us at the General Assembly, that we create some type of team for us here. And I think that'll be very beneficial for us, because we've had some other accidents, not the AED, cardiac arrest, but we've had some people fall and, fractures, and, just somebody say, well, just find Dexter or Doc. Then, we get there. But I think we need to put together a team for our legislators here. And I think Doctor, he wanted to mention about the liability, because if you do have a school nurse or somebody on this team, and teachers and others, that if they do the Good Samaritan situation, who's going to be liable if the batteries are not charged, if they wanted to pass or missing, those type things. So we just need to keep that in mind as well, the liability.
And for the last question, Representative Jackson.
Thank you, Mr. Chairman. Thank you for the presentation. In the legislation, are we just talking schools? Are we urging recreation departments too? Because it seems like this is an important issue that it could happen anywhere now. And as Representative Dexter just said, even in the General Assembly, it could happen with us. So are we talking recreation departments too, where sports goes on every day sometimes in our recreation departments in your legislation?
So with this, the ask is just for schools.
For
I couldn't
schools.
agree with you more, though. And there's actually literature looking at differences in events for young athletes who participated in AAU basketball, for instance, where they're not on the school setting, but they're participating, training at a set location, highly competitive. How are outcomes there versus in a situation maybe where they are at a school where many schools do have hopefully an emergency action plan. And so it's a really important point. But to be specific for this, the ask is just for schools.
Thank you.
I want to thank both of you for coming today and waiting out through the afternoon for us. I apologize, but sometimes we move slow.
No
So
problem.
thank you
We
very much.
appreciate it. Thank you so
Okay.
much.
Elizabeth Lively, would you like to come up and finish up on the MedGap? And thank you for waiting. I appreciate that. Elizabeth's been here since 11:30 today. At least 11:30, because we met at 11:30.
I know, I've had a grand time today. Thank you, Chairman Hawkins, Vice Chair Newton, and members of the committee. I'm really happy to be here today to talk about this pending legislation that's going to be introduced next session here in the great state of Georgia. So this bill has to do, like John had explained earlier, has to do with improving a bill that was passed in 2016 that provided access to Medigap plans for under age 65. But in the statute, there's a vaguely worded requirement that premiums should not be excessive. So there isn't a real premium protection, and in your packet you have this chart At the bottom of the chart has the wording from Georgia statute. And above that, you can see what the premiums are for individuals with end-stage renal disease who are under the age of 65. And I just realized I did not introduce myself, so I will take a pause. My name is Elizabeth Lively. I am with a patient advocacy organization called Dialysis Patient Citizens. We represent individuals, families, and caregivers who are in this world of end-stage renal disease, whether they're on dialysis or they have received a kidney transplant. And we work to improve their quality of life through work such as this, and also through education for them and for their families. So Medigap is really important because of access to transplant and that 20% out of pocket. So you can see on this chart here, there's some major insurers listed. All of this data comes from Medicare. It's accurate through this month. So if you're under age 65 and you purchase a plan, say from Aflac, if you're age 65, that premium is $161 a month. If you're under age 65, your premium is 902% greater at $1,614. When end-stage renal disease patients turn 65, they still have end-stage renal disease. So charging these exorbitant premiums for this patient population is really a fairness issue for them. And these patients want to be defined not by their disease. They just want to be treated like everybody else. So how will this legislation amend the current law? I'm just going to walk through the provisions in the legislation. It uses the same proven, same as age 65 premium protection that has been in place in the great state of Kansas since 1999. Data collected from Kansas shows this methodology works, has not driven up costs to the health plans. In fact, more than 45 insurers in Kansas write plans for under age 65 market. So if business wasn't good in Kansas, they wouldn't be there writing plans. This legislation also includes a one-time 6-month open enrollment period for those who are already enrolled in Medicare Part B. So this legislation takes a look back at individuals who are still under the age of 65, who were already on Medicare, and provides them an opportunity to buy this plan. The group of individuals who are in the market for this is very small. It's a group called non-duals. So these individuals are on Medicare, but they're not on the state Medicaid program. For dialysis patients, that's around 5,400 people. We're partnering with the ALS Association. Unfortunately, they could not be here today, but there's about 500 ALS patients who are also under age 65 who are on Medicare Part B. There's an interesting provision in this legislation that provides an opportunity to individuals who are age 65 or older. For those of you who are not on Medicare, when you purchase a Medigap plan or a Medicare supplement plan, my advice is to choose wisely. It's not the same as the insurance that the state of Georgia provides or that you would get in an employer, where once a year you can change your plan, you can change your insurance provider. When you purchase a Medicare supplement plan, that's it. You can change it, but it's outside open enrollment, and you're going to have to take a physical, and you're going to be medically rated, which means your premium is going to go way up. So this legislation has a once-a-year open enrollment period called a birthday rule. We passed this in Kentucky unanimously. It's an interesting take on the birthday rule, which is in a number of states across the country. This language allows you to change your insurance provider. You can't change your plan, but if you look at this list, premiums are all over the map. So once a year, you would have the opportunity to shop around for the same plan that you're written under, but you could change insurance providers to find a plan that better met your financial situation. That's called a birthday rule. Similar legislation to what will be presented here next year, this last year in 2023 was passed unanimously in the state of Virginia, was passed unanimously in the state of Kentucky. And it's going to really help a lot of individuals. So why do we need this? John Hoffman talked briefly about financial security. For end-stage renal disease patients who don't have Medicare supplement coverage, they're responsible for the 20% that Medicare doesn't pay. That can be up to $18,000 a year. So it's not out of the realm of possibilities that people are looking at that unbelievable medical bill. They're facing bankruptcy. They're facing choices. Do I pay my medical bills? Do I buy food? Do I pay rent? What do I do? And they can make the decision, I'm going to spend down my assets and go on Medicaid. And then the state pays for that. We commissioned an actuarial study, which you have in your packet from Health Management Associates. And we specifically asked them if they could provide data with us that would show definitively that people were spending down assets to go into the state Medicaid program. Unfortunately, they could not do that because every state Medicaid program is different. There just wasn't any way for them to run that data. But we know, anecdotally, hearing from our members, that people are doing that. So this legislation can help individuals stay off of the state Medicaid rolls. And I want to put a patient perspective in here just to give you an idea of what people are experiencing. And I want to talk about a 40-year-old. Her name is Christy Flynn. She lives in Vice Chair Newton's district out in Grovetown. Her kidneys failed when she was 25 years old. Up till that time, she was working as a special education care professional. But after she started dialysis, like so many patients discover, she just didn't have the energy to work. And she ended up spending down assets and getting on the state Medicaid program. She had a transplant. The state Medicaid program did pay for her transplant. But she wants to go back to work. But she will lose her Medicaid coverage if her income goes above $875 a month. So because she doesn't have access to an affordable Medigap plan, and Christy and I talked about this, and I asked her, can you afford, even up to $185 a month? She goes, yes, I could afford that if I could go back to work. But right now, I can't. And so for this, what she said to me was, for the state to keep me from working makes no sense. So here's an individual who wants to go back to work. So this bill can prevent people from going on Medicaid and can help them move off of the Medicaid rolls. John Hoffman briefly mentioned access to kidney transplant, and that transplant centers, most of them do require secondary coverage. I mentioned that Kentucky and Virginia passed this legislation. Kidney patients list at multiple centers across the country. This increases their odds of getting an earlier call for a transplant. So folks now from Virginia and from Kentucky can come in here and get listed at the 3 transplant centers here in Georgia and literally jump ahead in the line ahead of Georgians because they have this coverage. So this bill will really help. But the bottom line is, what will this cost the state? Nothing. These are private insurance plans. There are no budget dollars involved in this. If a fiscal note needs to be requested during the process, it's going to come back as no impact. But what will it cost to the other people who are on Medicare supplement insurance, the over 65? We hear from insurers that rates will go up exponentially, that people won't be able to afford it, which is why we ran this actuarial study from Health Management Associates. The last 2 pages of that report are specific to Georgia. And if the insurers chose to raise rates to add those 5,400 people, allow them to get access, premium protected, the same as age 65, the overall pool would go up by less than 2%, which translates into $4 a month. So for $4 a month for the overall pool to allow these individuals to have financial security, access to kidney transplant, and help keep them off the Medicaid rolls, that will be the opportunity for all of you to support this. So I thank you, and I'm happy to answer any questions.
Seeing no questions. thank you so much for spending so much time with us. And I want to thank this committee. And it's been a long day, and I really appreciate you sticking around for this and honoring these people that came to speak before us. Very proud of y'all. Thank you very much. And thank you, Elizabeth.
Thank you.
We are adjourned.